strains and everything, which is very traumatic for the patient's family. So today we will be discussing in detail about delirium. Welcome, Dr. Shafika, for today's session. I'm glad to introduce Dr. Shafika. She's a consultant in palliative medicine at Apollo Cancer Specialty, Chennai. She has done her post-graduation in palliative medicine from Cardiff University. And she has experience in working in UK and Malaysia, not just in India. So you'll get a wide range of experience sharing from her. And she has been a part of research publications and attended many conferences nationally and internationally. And her areas of interest, you can see it's adult oncology, pediatric oncology, and advanced care planning, and medical legal aspects of end of life care in Asia, which is a very important topic or need of the hour. Thank you, Shafika, for agreeing to come for this session and share your knowledge among the participants. Thank you so much, and over to you.
Thank you so much for having me and to be able to, talk on such a very important topic like you mentioned. I'm going to share screen. Is that okay?
Yes, ma'am. We already have the access.
Okay. Oh, it's already on. Okay. Oh, gosh. So today we're going to have just a roundabout look on a very important topic that we will be, here. How do I do this?
Ma'am, you just have to choose the share screen option.
Okay.
And just select the PPT which you want to share.
Okay, there you go. I think I'm doing that. Are we okay? Yeah.
Yes, just have to put it in the slideshow mode.
Okay, right. So today we're going to be talking about delirium. And as we had mentioned already, it is one of a very important topic. It's a very vague topic. And it gets really interesting. So what is delirium is that we can describe it as an acute onset, fluctuant, confusional state with cognitive, emotional, perceptual, psychomotor, and sleep-wake cycle disturbance. So that's like a very formal description of delirium, isn't it? But most of us have seen delirium, and we would probably describe it as restlessness, agitation. There's also a hypoactive version where the patients will seem quite, how can I say, very drowsy and sleepy. That's also a kind of delirium. So we're going to be looking into how to deal with these kind of cases. And especially in palliative care, we'll be seeing a lot of this, especially in end of life. So prevalence of delirium, let's talk a little bit about how common it is. It is, in end of life, it's one of the most commonest symptoms that we will be facing, especially in the last few days. I wouldn't say weeks. I think if somebody is undergoing weeks of delirium and that kind of unrest, it should have been addressed earlier. And that's one of the most important things about delirium. It's one of those symptoms that's very ignored. It's unrecognized. Most of the times, even the medical professionals in many fields, in many specialties, have a very vague idea about restlessness and how to recognize it and how to deal with it. Also, very easily said, they don't know that this exists and it's so prevalent in end of life. And that's why it's very important. End of life in all aspects, but delirium is more common in oncology patients. Yeah. One of the other things that we have to remember is that when we recognize a patient is restless or agitated and we deem them as being in delirium, we have to also remember in the back of our head, this probably is, heralding a decline. The end of life is here. You have to start thinking about a life expectancy being very small, short. So time for you to also, update the caregivers, like this is not a good situation. Unfortunately, because a patient is in delirium, what can happen is because of the restlessness and whatnot, all the symptoms of delirium, they also tend to mask other problems and other symptoms. For instance, if they are also being restless and dyspneic, they won't be able to really verbalize or tell us this, as opposed to a person who's, oriented. That's also a very distressing thing for us, because of this very heavy duty elephant in the room symptom, we tend to ignore the other symptoms, and well, they're suffering. So this delirium, it's not just bad for the patient alone to endure. It's also very distressing for the caregivers to watch. Any caregiver watching their mom or dad, in a very confused, restless, and they tend to get sometimes quite aggressive, and it's not a very nice thing for the patient to themselves go through. Obviously, in their cognizant time, they wouldn't like to be viewed in such a manner. It's distressing for the caregivers, and it's absolutely disturbing for the medical staff who are handling it, especially if they don't know what's going on, how to deal with it, or we're not able to treat it. So that's a very important thing to remember. So there are also types of delirium, like I mentioned, right? So there is a hypoactive, hyperactive, and then the mixed type. So hyperactive is said to be the more common type, where you see the patient being, slowly talking, slow vocalization, a bit withdrawn, sluggish. Most nurses would come to you and tell the doctor, hey, doc, the patient is looking very drowsy. So, the first thing that goes into our head is obviously, oh, drowsy. Is it an electrolyte imbalance? Is it, what's going on, and so forth. We don't think it could be part of a delirium syndrome. They can also present in a hyperactive manner with psychomotor activity. Psychomotor activities basically means they are looking quite restless, a bit agitated. They might not be able to keep their hands off of the IV lines or catheter that's been put in. That's one kind. And obviously the other one is the shifting between the two types of delirium. One of the fundamental features of a patient being in delirium is that it's a very waxing and waning sort of a symptom, right? And it's very fluctuant. And it fluctuates between the hyperactive and hyperactive thing. That's why it makes it very, very difficult for us to diagnose it. Unless, well, you've been in the field for 15, 20 odd years, and you're quite confident and you know how to pick it up and perhaps use it, screening tool or something, but we'll get to that. That's quite an interesting thing. So how would it appear outside symptoms of delirium? Like I mentioned, right, there are two types, hypoactive and hyperactive. So you have the agitated patient, the altered level of consciousness. Restless is the most commonest type for me, although they say, the patient being very hypoactive and drowsy. For me, the most common type is restless and agitated type. They can appear confused. They can have hallucinations. They can have disinhibition. That's also another very distressing factor for loved ones to watch their mom or dad who are in the bed. A normally dignified lady would be like pulling out and pushing away clothes and so forth. This is in India. We can see sometimes, India and most countries also, you can also see this sort of delirium sort of a syndrome, right? What it does is if we don't treat it, and if it's not under control, and if we don't palliate it, you end up shackling the patient up. I'm sure you've seen that, right? That the patient is very violent, madam, very agitated. We had to tie them up. So that's not very nice. So that's why it's very important to recognize and treat. So there's no need for anybody to be bound up unless there's a really good reason for it. And end of life is not one of the things that we need to tie up a patient when it can be treated. Inattention and irritability. So Move something. Yes. So, so almost 88% of the cancer patients in end of life can be noted to have this restlessness and agitation. It's called terminal agitation. It's a very common thing. Not that it does not show up in non-cancer patients, but it's very, very common, especially because, you know, in cancer, we tend to have a lot of primary predisposing factors such as brain tumors and so forth that cause. Just want to go back a little bit. I think I missed. Okay, I'll come back to that. Right. So how do you assess a patient in delirium? Well, there are 4 principles to remember when we are trying to diagnose and assess and manage a patient. So you obviously have to go through a thorough, careful history. And when a patient is delirious and agitated, they're not going to be able to give you any history, obviously. So you have to liaise with the caregivers. And you pick up all the signs and symptoms that I had mentioned just before the previous slide. Of course, make sure that delirium is not related to something else or similar medical conditions. Make sure it's not a seizure activity that we're missing. And then we have to understand the diagnosis of the patient. And this is very important. I'll tell you why in a little bit, but just recognizing it is not important. I mean, not as important as actually remembering what the patient and why the patient has this condition and if it's reversible and what are we going to achieve by reversing. Is this the goal of care that the patient and family want? Right? Like I mentioned, delirium tends to be something very, very common towards end of life. So at that point, we have to think about, you know, whether it's really effective to treat it or reverse the delirium. So should we be screening for delirium? Yeah, because I was talking about assessment and screening. See, that becomes a bit awkward, yeah. Should we be screening all the patients? Not really. It doesn't really make sense. That's why it's really important to just have a good look at the background of the patient that you're trying to treat. Make sure that it's not a normal person, or normal patient who's in withdrawal from alcohol or drug or so forth, right? You look at the patient, see if he has a terminal illness, and then if the illness, if there are any predisposing factors that could possibly be causing the patient to go into such delirium. So those are the patients that you can try and screen. The most commonest screening tool for this for delirium is confusion assessment method. It's I've put up the 4.1. If you look at the link over there at the bottom, that will take you to the, I don't know how one might be able to, maybe some of you can copy paste or something, but that will take you to the 9-point CAM tool, assessment screening tool for delirium. And this is one of the more commonly used. It's very easy, user-friendly, you can say. You don't have to be a psychiatrist or specialty trained medical personnel to do it. You know, all of us can do it. Even I can implement this tool. It's not too difficult. Some of the delirium screening tools and psychiatric tools can be very, very difficult for us who are not trained. It's pretty sensitive, 94 and almost 95% specific. So, you know, that there you have it. It's a very, very effective tool. It's short. Obviously, in a clinical setup, I'm going to go for the 4.1, obviously. And it's a good thing to have in the back of your head. On a side note, when you have a patient and you're in the palliative ward, I'm assuming we're all aspirants in being a palliative care physician, right? So if you're sitting in a palliative care ward, screening and assessment becomes sort of a thing that you kind of just do and go through in your head. the decision about what to do with the delirium patient in delirium is the one that will be taking up most of your time. I'll get to that, but just for us to, just to know, because this is an educational seminar, so we should know that there is a screening tool, an easy one. Don't screen everybody. Make sure you know a proper history and you suspect there's a proper reason for this, and there's a strong notion for this patient to be in delirium, and that's when you can implement this. Gold standard is obviously the DSM, type 4 TR. And I can tell you, practically it's good for you to have this in your notebook. You write it down. This is the gold standard. Hopefully, maybe somewhere along the line, somebody will give you a multiple choice question and then this is the answer. To practically implement this, it is a headache. It's very, very, very exhaustive, and it does require you to have some expertise. So for me, it's something for us to know in the background, right? And I've just taken this because I thought it'll be really nice if we can just have, if we just have a look at the, okay. So if we have a, look at this tool and then just sort of compare, can you see that the easiest one is obviously the CAM screening tool. DSM-5, and ICD-10, very, very complicated, very difficult to implement in a clinical ward when you have a patient so restless and agitated. One of the things you have to understand is when dealing with terminal agitation and restlessness, it's sort of I would consider it an acute palliative care situation. Sorry. Oh, no, sorry. Right. Yeah, so I've already mentioned this. The problems with the use of this tool is quite difficult. So let's have a look at the common causes of delirium. This is very important, and I've tried to simplify it as much as possible by going organ-wise. So of course, if we go with the CNS, patients such as stroke, who experience stroke, or they're having seizures, traumatic head injury, brain mass, brain mets, very, very common, hydrocephalus and infection, heart, lungs, and circulation, all these end-stage cardiac disease, end-stage pulmonary disease who are in respiratory failure, they can cause delirium and agitation as they become more and more hypoxic. Digestive and urinary system, hepatic failure, renal failure. In oncology, hepatic liver mets causing hyperbilirubinemia, icterus, and all of that is a very common situation where you would find a patient either going into the hyperactive, more drowsy sort of delirium, or more very, very restless. And in renal failure, in renal shutdown, you might see a patient who's very uremic, and that will also, present to you with restlessness and agitation. So we must know how to treat it, because it's very difficult for the caregivers to watch this, either at home or in the hospice setup. One of the very, very simple reversible things are like constipation and urinary retention that can happen in a person who's in end of life, but it's also something that is quite reversible. So you should always keep those reversible things, in view, in the back of your head, so that you can get them a bit more comfortable and, treat the cause. Endocrine, thyroid, parathyroid, adrenal, not very common, obviously. Metabolic, one of the more commonest delirious state is when you see all these patients who have hypercalcemia, where we might see it in patients who have skeletal mets and advanced cancer. Dehydration can also be a very common, easily correctable cause for a patient to go into delirium. Obviously, toxicity and withdrawal is also very, very common. So a patient who's been started on morphine, perhaps we were eager to get the pain under control, and we end up sort of escalating the dose quite fast. That can set off a lot of restlessness, toxic delirium. So this one would require us to very simply just taper, stop, think about opioid switching. Yeah. So these are the common reversible causes of delirium, right? In the elderly, when our terminally ill patients or the elderly patients who are suffering from chronic illnesses, what tends to happen is they will have diabetes, they'll have hypertension, they'll have a cardiologist involved, there'll be a geriatrician involved, and then finally we are also involved. So the patient will end up having polypharmacy, and if we have to end up being somebody who just collates everything and then just has a look, and we should some elderly patients, geriatric patients on palliative care would have been on very useless medications for over 10 years that nobody knows who started them. Nobody, the caregivers won't be able to give you a clear picture of who started, when it was started, but it's just been there all the time. And yeah, that's one of the things that you can very easily reverse. Opioid rotation. So opioid rotation and opioid switching quite commonly causes this sort of an agitation and restlessness, but more like the drowsy patient, the hypoactive type of delirium. And a very, very common presentation of opioid rotation and switching is myoclonus. So I don't know whether you've heard of this, but there's always a situation where a patient might not be responding to morphine quite a lot. And then we decide like, hey, it's time for us to think about switching to methadone or maybe fentanyl and stuff. So when we switch a little too fast or a little too slow, can send the patient into this sort of delirium. And a very common presentation is the myoclonus. Yeah. So dehydration, the elderly always are very, very prone to dehydration, even with a bout of 5 episodes of loose stools, which we would have given some Ducalax to, a lot of medications also towards a patient in palliative care. We tend to give aldactone for ascites or Lasix. If we don't watch carefully, they might become quite dehydrated. Hypercalcemia, I already mentioned, right? Bone mets, cancer, very, very common causes. Hypomagnesemia, the thing they really hyperactively check for in ICU, but I truly believe that a patient who's on palliative care should not be in the ICU, but it's also another cause. Urinary tract infections and sepsis is another very common cause of a patient that can go into restless or drowsiness as well. So we should always keep that in the back burner. Anti-cancer medications tend to cause a patient to have this very cute term, chemo fog and so forth. So if a chemotherapy agent is causing this drowsiness or delirium, it is one of the reasons for an oncologist to think about alternative chemotherapy. So I would like you to remember that, because any chemotherapy that we give to a patient should be helpful. And if it's causing distress, it's an indicator for us to move away. I'm sure one of the most commonest things that we would be seeing on the ward in oncology, at least with lung cancers, is SIADH, which can also cause a bit of delirium and so forth. So easy ways to treat them, right? You treat the cause. Polypharmacy, obviously, withdraw some of the unnecessary drugs. How to treat them. This slide is about how to treat all these reversible causes, and then we just wait and watch and hope that the restlessness and all settles. Opioid rotation, obviously we have to either switch or decrease. Dehydration, intravenous IV fluid resuscitation is the best and the easiest method. Infections, antibiotics, and other supportive measures until the infection settles, and ideally the delirium also settles. Hypercalcemia, hydration and biphonates. Hypomagnesemia, of course, IV replacement. Correct hypernatremia and SIADH patients, and anti-cancer treatment, like I mentioned, right? There are a lot of medications that actually in chemotherapy that tend to, like capecitabine, if I'm not mistaken, tends to cross the blood-brain barrier, and thus thereby causing all these restlessness and agitation. And again, it's an indicator for the oncologist to switch to another line of chemotherapy. Now, when we talk about how to treat and how to manage, how to manage hypercalcemia, delirium, we have to look into a few things, right? So I'd like to just, okay. So there are non-pharmacological interventions and medical management of it. I'm obliged to bring it up, but I do feel that delirium cannot really be corrected by these medication sort of interventions. I've not really seen too much benefits, but it's always good to hear. It might be a supplementary sort of way to keep them calm, but this is not a sure way of getting them to settle down. Yeah, so it's good to remember these, but it doesn't really work. That's what I'm saying. It's a supplementary thing. So if you have a patient who's got cognitive impairment, right? So what you can do is this is obviously a patient who has dementia and, is confused, he's been hospitalized. That itself will cause them to go into a sort of agitated, disoriented sort of condition. We can, by keeping the staff and the caregivers consistent. Like if nurse A, B, C, D are all working the shift, preferably if this patient seems to have dementia and having delirium and restless and agitation, might be worthwhile to ask the ward in charge to stick one nurse to that patient. That would be kind of helpful. Constantly reassuring the patient, explaining to the patient, even though he keeps asking the same thing. Use clocks, windows, open up the shades, let them know the day and night difference. That also makes a huge difference. If they're visually impaired, might be helpful to get them glasses from home. Hearing impairment also, when you can't hear, obviously it really messes up your whole senses. So it does, makes a difference to get them a hearing implant. obviously that's how we can talk to them and reorientate them, right? Well, when a patient is in palliative care, they become immobile. There's not much we can do, but what we can do is, with the help of a physio, get them up and make them sit down for a little bit rather than just letting them lie down in the hospital bed for the long period for 3-4 days. The elderly, dehydration is the most commonest. And if it's not an acute hospital, and if it's a proper hospice where IV fluids are not really playing a thing, you can encourage a bit more water or ice tube fluids. Sleep-wake circadian cycle is also a very important cause for a delirious patient. So it does help to expose them to sunlight, perhaps get them on a wheelchair, take them out for a roundabout. Obviously, no tea, relaxing bedtime routine, all those help. But again, I do believe that delirium is a very acute syndrome, and medications, this kind of intervention will be supplementary. It's not a treatment mode, right? So before trying to manage and treat delirium, it's really important at this juncture to step back and have a review of all the underlying diagnosis and prognosis. Diagnosis is very easy. Flip open the file and you have a good reading of what the patient and possible the cause also, you can figure it out. Prognosis is important. I'll tell you why, okay? Why is it important to look into prognosis? When a patient is in end of life, and there are certain things in the body that naturally allows a person to shut down, become drowsy, and that helps, right? Now, if we go and correct these things that are helping the patient become more drowsy and sleepy and maintaining their dignity, then we are sort of intervening with the natural death, actually, and meddling with that can be not the right thing to do. That's why it's very important, right? Once you know the diagnosis and you have a rough idea, like prognosis, is this person in terminal agitation? Does he have 10 days or 3 days, or are we looking at a person who possibly, if we reverse this, has 6 more months, right? That's very important. Then you divide the cause into reversible or irreversible delirium. Irreversible delirium, obviously, we can't do much. Reversible, I've already given you some heads up. Small things like hearing aids and so forth. If that reverses and then you give a person a good solid 3 to 4 months, not causing any distress, is worthwhile for us to treat, right? Also, you want to have a check with the patient. If the patient is, obviously the patient is not, doesn't have the capacity at that very moment when he's agitated and restless. So, or he might not be too coherent. So you check with the caregivers and find out the goal of care for that patient. It's very important. Again, if their goal of care is to keep him comfortable and dignified, then we really have to sit and rethink whether we are going to investigate further. We're going to allow the natural way to go. And even beyond that, if the person is restless, are we going to do something about it? What's the most important for the patient and his caregivers, and what are their goals of care and expectations, right? If the caregivers have an expectation of we want this restlessness to settle and then we want to take back home, so it's very important to not just find out goal of care, because it's very easy for a lot of patient attenders to say, yeah, we want palliative care, we want comfort care. but and then they will have a small disclaimer. They might say like, oh, we also want to just get him better a little bit and then get him home. So delirium, guys, it's a very wonderful topic because it's it's a bit of medicine, it's a bit of ethics and medical legal aspects. It's a whole load of fun stuff. It's not just easy. It's not an easy. There's pain, and then there's pain management. There's a ladder. So straightforward, isn't it? When you look into a symptom like pain. But delirium can get very, very difficult because it really requires you to sit down and think about think about how to treat, should we treat, I'm so sorry. Something happened. I'm so sorry. I apologize. Where were we?
You were in the minus.
You can still hear me, right?
Yes, ma'am, you're audible.
Oh, okay. Sorry about that.
And the screen is also visible, not in the presentation mode.
Okay, cool. Right. So that's one of the things that I wanted to talk about is delirium but my tab isn't working. It was working fine 5 minutes ago. Now it's working too much. Okay. Right? So that's what you have to remember. So pharmacological management of delirium. So this is a fun fact that I had to find out very in a very bad, I mean not bad manner, but it was a growing thing, because I always try to look for why don't any textbooks actually give me exact dose or which medication to use. It's always me going around and seeing a senior palliative care physician or oncologist on the ward using their own cocktails to take care of patients. So, there is actually no medication as per the US FDA that with approved indication for the management of delirium. So if you go have a look, guys, not many textbooks will actually give you a sure dose and this is okay and this is okay and stuff. They'll always give you a very vague thing. And when you're dealing with such a common prevalent symptom in palliative care, you really have to find your own medicine and what works best. So there are no published, no trials, for the, actual management of delirium. You won't find many textbooks actually telling you this is okay and okay and okay. Because obviously, like I said, delirium is very difficult. Most specialists do not, will not be able to recognize it. And when they do recognize it, they understand its restlessness. They get a bit, how would I say, hesitant to pile on, to start medications to sedate. That's exactly what we're doing in delirium, right? We're trying to sedate the patient and keep them comfortable and make sure they look dignified, which is the key, aspect of palliative care. So there is also no consensus statement, from oncologists and geriatricians and even palliative care physicians. Most of us, we won't openly talk about sedation because it becomes very tricky. You see, the first thing the caregivers will ask you is like, if we start sedation, are we speeding up his passing on? So, these kind of questions will come up. So we do have to, it's a very nice thing to be really good at. Managing delirium in the end of life is an art, and you sort of just grow. You kind of have to experiment with different things. Yeah. So what we have to do when we have a patient, we see a patient, we suspect that they are restless. You have to start us divide them into you have to divide them into 3 groups, right? The ones that are reversible, hyperactive delirium. What do you do? Okay, and then the second one, it's very important. This is worthwhile for you to kind of mug and keep, because it's just 3 points and the treatment options is so simple. Simply because, again, there's no proper consensus statement also for which drug to use. There's just a recommendation what not to do, right? So irreversible, hyperactive delirium. What we can, then what we can do for them. Hyperactive delirium also. So very easy, right? Reversible and hyperactive, irreversible and hyperactive, and hypoactive. Hypoactive means the drowsy, slurring of speech. That's also a kind of delirium. So when you have a potentially reversible hyperactive delirium, right? It's very easy. It is an acute syndrome. It's an acute setting. It's an acute problem. So you do things a bit more faster, right? Please don't, yeah. Oh, sorry, I went into the chat box. So we don't need to really escalate too many things. We don't wait for 2 days, 3 days before switching or increasing the dose. That's something that we need to remember. It is an acute thing. So if one doesn't work, please move on to the next medicine for restlessness. Try to palliate the symptoms, the other symptoms that are alongside. Like I mentioned, right? One of the greatest drawback about a patient in delirium is that a delirious patient will mark all of his other symptoms. So you should look, have a high suspicion if the patient has, breathlessness, that is visually, you can see that he's restless, but then you can also note that he's a bit breathless and dyspneic. Might be worthwhile to see if it's something very simple like pleural effusion. You should palliate that. You should remove the fluid. That will bring down the restlessness and help other, and that will also help with calming the patient down and responding to the any medications we give for the delirium. So the most recommended medicine for this kind of reversible hyperactive delirium is first generation antipsychotics, such as haloperidol. Haloperidol is also, I think, the trade name that's quite common in India. It's called Serenase. Very commonly used, very safe to use it. This is one of the recommended medicines. So again, when I was going through checks, it didn't openly say that we can use haloperidol. It said a good recommendation is to use first generation antipsychotics. And with my experience, I feel the best one is haloperidol. It's very safe, doesn't speed up anything. You don't have to worry about respiratory depression and all of these things when, your colleagues might give you a bit of restlessness yourself, and when a patient is, not well and we're trying to keep them comfortable, and then think about using something like morphine and all. So this one is quite safe. And when you use it and you feel that it's successful and the delirium has settled and you have managed to also treat the cause of the onset of this restlessness, then you can slowly taper the antipsychotic. So starting dose is usually 1 to 2 milligrams. You can repeat haloperidol until you reach a point where you think, yes, this is the dose that's working for my patient presently. So I don't believe a lot of institutions are comfortable with subcutaneous. So I'm going to go with IV as an example. Oral, again, they might say it's a feasible method, but when you have a restless patient, it's really difficult to get them to eat a tablet. And the dose of haloperidol can be repeated every 8 to 12 hours. I think 12 hours is too long. Most of the time when you give IV, the clearance is within the next 3-4 hours. So you might be left with, the rest, the delirium starting up again. So in such a case, there's no role for opioids. That means no morphine drip, no morphine bag. The second and third generation antipsychotics have not shown much use. Old school haloperidol, fortunately, is really good. So that is something that you can use, right? This is for reversible patients. So irreversible hyperactive delirium. Now here, we're obviously, the patient is in end of life. It's probably the last few days. And the cause is not going to be easily reversible. Obviously, if it's something like malignant bowel obstruction or even renal failure, all of these, it's come to a point, it's just not going to be feasible for us to actively contribute to getting the other symptoms and everything. So here we can actually use benzodiazepines. They are very, very good. One of the best medications in this group that I have found myself using quite often without being scared, because the clearance of midazolam is a couple of hours, so I can confidently tell my ICU colleagues to not become restless themselves over the use of midazolam in the ward, as opposed to using morphine drips. So this is a situation where you can find in uremic patients in end-stage renal disease, in patients who are in liver failure, and they've got icterus and they're quite restless, brain mets. So one of the starting doses is a small thing that I do is that I know for me to indent and get midazolam onto the ward is going to be a bit of a hassle, but they will always have an emergency while somewhere in the ward. So what I do is I usually give a stat dose to the patient. Maybe, if it's a hefty patient, I would give a bit of around 5 milligrams also. Very, very calmly, I can give that, a stat dose, slow IV push. Or if it's a small, tiny cachexic patient, maybe 2 to 3 milligrams IV stat, and then ask the nurse to set up a infusion pump with a syringe pump, and maybe start with a dose of about 3 milligrams per hour, 2.5, 3 milligrams per hour, whichever you're comfortable with. And this dose, right, it's something that as you use it more confidently, it'll come to you very naturally what this patient requires and so forth. But in India, this is the best for me, and it also is a medicine that most people are very comfortable with, because if you look at haloperidol, the clearance is almost 12 hours. Okay, so it lingers on in the system. It makes a lot of angst with a lot of other medical professionals, especially nurses and stuff, ICU nurses. So midazolam is really good. There's another very There's another combination that I saw a lot of my colleagues using before. It's a very reasonably priced one. It's a combination of Fortwin and Finnergan. I mean, let me know in the chat box if you've heard of this Fortwin Finnergan combo. It's a nice one. It does work. It's really good. But again, it's not very well documented. So that's why I feel very, a bit anxious about it. But I know using midazolam is quite openly discussed. And the third one is a hyperactive delirium. So treatment of both reversible and irreversible hyperactive delirium with medication is not recommended. Avoid pharmacological intervention. If you think there is medicine that is precipitating all of this, then try to taper it. Don't stop, withdraw, taper gracefully. In this situation, in a hyperactive delirium, where the patient is more drowsy and so forth, all of our other visual aid, hearing aid, getting their own stuff into the hospital bed, like their own blankets and all, those are all, like supplementary interventions that are very, very helpful. And here, the only thing we can do is to palliate the other symptoms that are there and not focus on this kind of delirium. So it's not the end, sorry. There's one more thing I wanted to bring up. In a person, when we have terminal agitation or restlessness, in end of life, right, our body isn't shut down. And when we have skeletal meds and we have respiratory failure, you go into hypoxia, and that's how our body shuts down, right? And if you look at hypocalcemia and hypercalcemia, they also, ultimately there might be a progression, but they get into this hypoactive delirious state. And they are in end of life. And it's a natural way. The body is producing these sedative agents to help the patient become more calm. And in this stage, in end of life, if we, in a hospital setup, unfortunately, we do tend to sort of go and do blood tests. And if we do blood tests, we tend to correct. And when we correct certain things that are helping a person be calm and comfortable in their end of life, then we are sort of messing about with the natural way, the natural death, as one can say. So that's why I go back to, the part where I was talking about prognosis and goal of care and so forth. It's very important before you start, all these interventions to reverse a reversible cause, even in a reversible hyperactive delirious patient, please take a moment to speak with their caregivers. It is very important. That's why this is very interesting. Even though you have you've been loaded with, you have a loaded gun with all of these medications that can definitely help you through getting to treat delirium. You have to stop for a moment, and that's where we are different from any other specialty, because we are the physicians who are taught to actually think before intervening. Is it worthwhile to sit and treat just because we can treat, when actually the goal of care for that patient is to keep them comfortable? So there you go. That is one of the things that I would really like you to take a moment and think about and remember, just because you have a medicine that can help and you've been told that you can treat delirium, should we treat the delirium in that patient? Each patient is different. Each patient has a different goal of care. Each patient will have their own caregivers. So always take a moment. And before intervening, and just because there's a reversible cause over there, please don't aggressively reverse what is the body naturally trying to do, and give the patient a natural sedated measure. So that's one thing I would really like you to think about. I know I have a lot more time, so I want this session to be a little bit more interactive. So is it okay if we have a question and answer session?
Yes, please.
Yeah, so I'm going to stop sharing and I want to see the rest of them. Yeah, there you go. So I'm happy to take on questions for now. Anybody has anything particular? I just want to know also, does everybody know how to recognize a person who's in end of life? Is there, are there like big signs for a patient in end of life? Delirium and agitation and terminal agitations are all conditions that you see in end of life care, end of life of a patient. So it's very important also, before going through all of this, we need to also know how to recognize a person who is dying, actively dying. Yeah. Any questions? If anybody's shy, you can always put it up on the chat group also, chat box.
I have a question, please. I have a question.
Yes, please go ahead.
Yes.
Yes. Is there any are there any dose modifications for the haloperidol and midazolam in patients with like deranged LFT or renal impairment?
Right. That's a very interesting question. Okay, Sharon, right? So I love this question because it gets back to exactly what I was saying. A terminally agitated patient, right? We shouldn't really worry about how we're going to correct the LFTs and RFTs. No matter what we do in this juncture, especially if they are in end of life, we have to sort of think more about their dignity and keeping them calm and bringing down the distress levels of the patient as well as the caregivers and your nurses. Most importantly, a restless patient, we go and put the medications. The nurses will be really dealing with it day in and day out. Haloperidol, yeah, definitely it's hepatotoxic. So it is a concern. But when we are dealing with a reversible cause and we're looking at getting the patient back in a couple of days, we should be aiming to control the symptom in the next, in 48 hours. And then do review the LFTs and RFTs. And we are using small doses only. This is not going to, we're not doing 40 milligrams at a go. So it's a much, 40 milligrams, 40, 50 milligrams at a go is a bit awkward. So start small, keep tapering it up, control the symptoms, do it as soon as possible, and keep an eye on your LFT. I can't hear you, Sharon. Yeah, is that okay? So since nobody is coming up with questions for me, I'm going to start asking questions. So can we have somebody just tell me what are the signs and symptoms of end of life? Last actively dying patient. What do they look like? What is the symptoms? Any common symptoms? You can type it in the chat box. Don't make me call out your names. So please answer before I start calling out names. Yes, thank you, Rishikesh. Dyspnea is definitely one of them. Terminal agitation, restlessness is a big, red flag of impending, yes. Restlessness, agonal breathing, excellent distress, agitation, loss of appetite.
Their intake, oral intake, urine output progressively decreases.
Yes.
They become more bedbound, definitely not move around.
Any more that says like, hey, this patient has maybe 48 hours so that you can really call in the loved ones? Impaired consciousness, yes, very important. They become very drowsy.
A death rattle is also very common in the last 48 hours.
Absolutely, absolutely. Death rattle. Anything in the urine? Any changes with the urine? Urine output is reduced, and whatever output is there will look very, very dark colored, obviously because of the renal shutdown also. So that's also for me a big, big sign. Yes. So why I'm asking you to list out these sort of what are the symptoms? Death rattle is one. Obviously, the glaring signs are decreasing SiO2 and BP also dropping, and the heart rate will be going the other direction, either very high or very low. So these are the signs that also start telling us, especially the saturation, that they are actively dying. They have probably 3 to 4 days left, if not less. So why it's important is, these are the patients you don't try to intervene. Breathlessness, dyspnea, respiratory failure, all of this causes hypoxia. Hypoxia itself can cause an hypoactive type of delirium. And it's a natural sedation that the body, a shutting down body, is giving the person. So if we go and correct this, we might actually exacerbate a terminal episode. So there's also a study that says that IV fluids in end of life in an actively dying patient can cause, is associated with increased incidence of terminal agitation. So when a patient is passing on naturally, there are certain things that the body is already doing and releasing inside our body to keep us sedated and go through this in a dignified manner until we intervene. So that's something I wanted to bring up. So there's hypoxia and there's hypocalcemia or hypercalcemia also. They tend to go into a very somnolent state. So those are all situations where don't intervene just because you can. Just let it be. Yeah. Yes. I believe that is one of the reasons for funny thing about endorphins getting released in the last end of life, is that there is, if you notice, right, if you've seen actively dying patients one after another in a hospice, you might notice that just before passing away, granddad or grandma is a bit more active that one day. Everybody is so happy, things look a bit more brighter, everybody is wondering why he's up, smiley, he looks so bright, he just asked for last tea, he asked for tea, we gave him tea, is he getting better? And then next day there's a surge down, right? So that endorphin release is probably the reason. It's a Revati who had mentioned it. That's something for you to look out in the hospice. No one has any
Ma'am,
questions?
I have a question.
Sorry.
Yes, I have another question. Yes, for patients who are at home, like nobody is there to give them any subcutaneous or IV injections. So is like sublingual lorazepam kind of an option for restlessness, or but I mean, I found, of course, it acts for a very long time, and then they become drowsy for the next 2-3 days. But then, apart from, I mean, is there any other option, or is that what we'll have to resort to if we don't have anybody to give injections?
Absolutely. That's such a nice question. Obviously, we have a lot of patients in palliative care who wish to be at home and wish to, or be in the hospice, right? More so, they tend to ask to be at home. At home, if you ask me, it's actually difficult to manage this terminal agitation because it's not even that, they don't know how to use the subcutaneous infusions and all. It's actually legally in India, we're not allowed to dispense injectable forms of morphine or even haloperidol, even midazolam. So we have to resort to lorazepam. Midazolam nasal sprays are available. These are made for basically patients who go into fits, right? As an emergency thing, we tell all our seizure patients to carry these midazolam nasal sprays. So that is an option for you to keep in mind. If you're giving a care package for a person who wishes to have end of life at home, midazolam nasal spray is a very good option. And my age-old thing that I turn to is morphine. Crush it, higher dose, 30-40 milligrams. Even if it's not getting absorbed, we hope at least 30 to 40% of the powdered version, we put it in the buccal mucosa, and we hope that helps. There are sublingual forms of lorazepam, like you mentioned, and we really don't have to worry if they have made their goal of care and wish to be at home for end of life. We do not have to worry about them being sedated next 2 days. If this was a patient that is expecting to come back for chemotherapy in 3 weeks and they're sedated for 2 days, then we are in trouble. Yeah. So end of life at home, I would say try anything you can and get them sedated. And terminal agitation that is not being helped with this, with all of our medication at home, it becomes an intractable symptom, and it's a reason for them to get admitted in hospice or inpatient in a hospital for, for end of life care. So, and there's one more thing I want to bring up, and so at home, what happens with end of life care patients is that they don't do bloods. We should encourage them not to do bloods. So if they don't do bloods, and again, all of the shutdown, the multi-organ shutdown is happening, it will all cause a natural sedation. So we don't, that's why I'm telling you, people back in the day before medical interventions came about died much more peacefully. It's, that's the way. So most patients die much more peacefully without needing a lot of interventions. It's the ones that get admitted, and then we do bloods, and before you can get to the emergency room and tell them not to do bloods, somebody has already corrected the hyponatremia. That's how it goes all haywire. So at home, use anything that's sedating. Don't worry about the part where I said morphine doesn't, no benzodiazepines and opioids are of no use and everything. Opioids are useful for everything, including dyspnea and everything. And when we are having a patient who's actively dying, they're probably not going to be able to swallow. Probably not the best advice, but if a patient is going to a remote area, I would sort of encourage a Ryle's tube just to get our comfort medications across. Yeah, because where are they going to run to for a nurse at that juncture? So I would say encourage a RALS tube, put in extra doses of morphine. There's really nothing wrong in actually sedating a person who is restless at that stage. Okay, that's a very good question. Thank you, Sharon.
Any other questions from other participants? Either you can send it in the chat or you can ask.
Midazolam lollipops can be used. If you have access to it, please tell me where I can get them. We don't have them in Chennai. We have fentanyl lollipops. We have fentanyl lollipops. Lorazepam sublingual also is not really available in around the area where I practice. Comes and goes. Accessibility.
Yeah, even I have not seen. I've seen nasal sprays, but not lollipops. Nasal sprays are something that we can give patients home, but sometimes we may not get the adequate dose.
Yeah,
Usually they come in very small doses, so they may have to take multiple sprays.
that's right. That's right. That's actually those midazolam nasal sprays are made for pediatric patients for seizure disorder, right? As a first line when it happens outside. So I would tell most of our patients are adults, right? So I would tell them to give at least 2 to 3 puffs in each nostril.
No more questions. Today we do not have a case presentation. So usually every session we have one patient story coming up from the participant side, but unfortunately we couldn't do that today. So we may not have a case presentation today. So if there are no more questions for Dr. Shafika, probably we can wind up today's session. And as she mentioned throughout the session, these things are very important because it's very distressing for the family to see someone in agitation. They might have had a very dignified life when they were conscious, and then suddenly they start doing so many weird things, and that's something that the family remembers all the time. And many places they restrain these kind of patients, which is again traumatic for the family. So it's very important to understand and manage. Yes, Ian, please go ahead.
Oh, unmute. We can't hear you. Can we unmute for him?
Thank
Hi.
you. I found this absolutely fascinating, and I really, from a UK perspective, admire your amazing way of getting around some of the problems of administering drugs to people. I would echo the key decision is when someone's actually entering an end-of-life situation and having that conversation, often with the patient and with the family at the same time, about what your aims with the treatment is. And fascinatingly, the drug selection is almost identical. So using a syringe driver in a home setting is normal. Being able to give continuous morphine infusion with midazolam and adjusting the doses every 24 to 48 hours is normal. Having a district nursing team who will change the drug 24 hours. I can't believe how blessed we are in the UK situation not to have to worry about having any of these drugs. I have learned so much about alternative drug administration and ways of getting medication into people. So it's fascinating that the actual medication approach is very, very similar indeed. We use haloperidol often for nausea control, but obviously sedative effects. The selection's the same. But
Nausinan, isn't it? Nausinan is not available here.
It's just the ingenuity is amazing. So I've learned lots about ingenuity today. I thought it might be helpful just to say that the approach is very similar, but you're very, very inventive. And I've learned about, I didn't realize there's all sprays for fits. I haven't got past suppositories, but brilliant approach. So thank you very much indeed. Fascinating presentation.
Hey, one more thing about, how inventive we are. I think it's really important, all of us here, we will definitely have our own cocktail mixes for delirium, and we'll be learning and fine tuning it. And it's so important. If you have something, please share, because a lot of us are struggling. Our numbers are so small, and we end up taking care of vast areas, and we keep sending patients to faraway places. So anything that you have experienced, for instance, like I mentioned, a 4-twin pentazocin as well as 2 cc of Finnergan put in 500 ml of DNS and then set at 75 ml per hour, right? This is a very common thing used in Tamil Nadu. And I came here, and this radiation oncologist taught me how to use it, and it's quite effective. It's really effective. And I for the life of me, I can't find it on record anywhere. Because I was like, what is this? I'm not using anything that's not being said in a proper book, in a textbook, but it's not there. So that's why, if you guys have something, it'd be really great if you just voice it out in sessions like this. It will help so many people, because all of us are, we're all practicing in different areas, I'm guessing, and we're going to be practicing in different areas. So if you have something, please let us know. Especially with delirium, it's very, very difficult and very distressing. It is something we should really, get a hold of.
Thank you so much, Ian, for the comment. Thank you, Shafika. I think there are no more questions. We can wind up today's session. I can't see anything in the chat also. So I'd like to thank Shafika for her time and agreeing to be part of this program and sharing your experience for all the participants here. And thank you, participants, for responding in the chat and asking your questions and making it interactive. Sripriya?
Thank you, Dr. Shafika, for joining us and sparing your time from your busy schedule for our participants. Thank you so much. And thank you everyone for joining. Before we sign off, just 2 updates.